Okay, teacher, good morning, friends. My name is Roberto Guevara, and this is Medical English A. And today I'm going to talk about Dapagliflozin and cardiovascular outcomes in type 2 diabetes. Okay, definition. Diabetes mellitus is estimated to affect more than 450 million adults worldwide. The prevalence is increasing, and it is expected that more than 640 million adults will have diabetes by 2040. Patients with diabetes are at high risk for adverse outcomes from atherosclerotic cardiovascular disease, heart failure, and renal disease. The high risk of heart failure in patients with diabetes is independent of the coronary disease, and limited data are available to guide treatments for the prevention of heart failure. As a result of this intersection of diabetes, atherosclerotic cardiovascular disease, and heart failure, the importance of determining diabetes therapies that are not only safe but also effective in reducing cardiovascular risk is paramount. Now let's see a video.
Type 2 diabetes represents one of the biggest challenges to healthcare today. Statistics show that 1 of every 11 adults worldwide is living with diabetes. Globally, there were 415 million people in 2015 with diabetes, and this is projected to rise to 642 million by the year 2040. Of these, 90% have type 2 diabetes. The presence of T2D represents a substantial burden to the individual, the most important of which is cardiovascular disease. Over half of all deaths in patients with T2D are caused by CVD. This means that a 60-year-old man with T2D who has also developed CVD has a 12-year lower life expectancy than his counterpart in the general population. There are many therapeutic agents now available or in the pipeline for treatment of T2D, and establishing their cardiovascular safety has become a key factor in the approval process. Dedicated cardiovascular outcomes trials, CVOTs, are now mandatory for all new agents. The Across T2D program was initiated with the aim of providing education and resources within the Central and East European region for healthcare professionals who manage.
Okay, now let's see applications in medicine. Dapagliflozin is a selective inhibitor of the sodium glucose cotransporter 2, also called SGLT2, that blocks the glucose resorption in the proximal tubule of the kidney and promotes glucosuria. Other SGLT2 inhibitors have shown favorable cardiovascular effects, including a reduction in the risk of hospitalization for heart failure, predominantly in patients with type 2 diabetes and established cardiovascular disease. They have also been shown to delay the progression of the kidney disease. The glyphosine effects on cardiovascular events, on thrombolysis and myocardial infarction trial evaluated the effects of dapagliflozin on cardiovascular and renal outcomes in a broad population of patients who had or were at risk for atherosclerotic cardiovascular disease. Let's continue with the video.
For healthcare professionals who manage patients with T2D. A range of tools and information has been developed in collaboration with primary and specialist care experts who hail from the fields of cardiology, endocrinology, diabetology, and nephrology. These fair and balanced resources are aligned to the needs and challenges facing those involved in the complex care of patients with T2D. The online resources are also a helpful tool for the high-quality series of educational meetings delivered by the medical experts. At the most recent event in Vienna, the expert faculty met with more than 150 delegates to discuss the areas of outstanding medical need in the management of patients with T2D and the clinical relevance of the data being generated from the CVOTs. In particular, discussions on two CVOTs that have shown a positive benefit in cardiovascular outcomes, EMPA-REG outcome for empagliflozin and LEADER for liraglutide, illustrated how the CVOT data can be practically interpreted across clinical specialities. This Perspectives paper summarizes the wide-ranging discussions on the challenges of managing patients with T2D and introduces the concept of new dual treatment paradigm that addresses both the glucose lowering and cardiovascular needs of these patients.
Now, okay, now let's talk about the pros and cons. Pros is dapagliflozin works on your kidneys. It increases the amount of sugar removed from your body when you pee. It also, unlike any diabetes medicines, this one does not make to gain on weight. In fact, some people find out they lose some. Cons: if you're taking dapagliflozin with other diabetes medicines, it can sometimes cause hypoglycemia, so be careful. For type 1 diabetes, always carry your alert that says you're taking this medication because it can increase the risk of a diabetic ketoacidosis. Another video.
So my overall impression was that this trial, like other SGLT2 inhibitor trials, again proved that there is substantial benefit in terms of reduction of heart failure hospitalization risk. As you know, there was a split primary endpoint of this trial. The MACE endpoint did not reach statistical significance, but the combined endpoint of cardiovascular death and heart failure hospitalization did reach the endpoint, which was positive. I think it's adding in several ways. So one issue obviously is that it further reinforces the issue of safety. In this trial, at least, we did not see any differences in the risk of amputation. So that was answered. That was a big question that was in people's mind. The second question that was in people's mind was that this trial had the largest cohort of patients with risk factors but without atherosclerotic cardiovascular disease of all the SGLT2 inhibitor trials. So the question was there any benefit in the primary prevention versus the secondary prevention cohort? And then the third is just the overall body of literature regarding SGLT2 inhibitors and management of diabetes. So for these reasons, this is sort of the fulfills the picture, and that's another plug that you can put in the vast amount of literature we have. So the limitations of the trial are that, again, so this is a randomized controlled trial that included patients either with cardiovascular risk factors or with atherosclerotic cardiovascular disease, but a big proportion of patients with diabetes out there, shorter duration of diabetes, actually have no cardiovascular risk factors, and they were not included in any of the clinical trials per se. So that is sort of one thing that we have to be careful about.
Okay, issue applied in Ecuador. In Ecuador, in the town of Riobamba, eligible patients were enrolled in a 4 to 8 week single-blind run-in period during in which all patients received a placebo, which you all know it's a medicine that does nothing. And blood and urine testing was performed. Patients remain eligible after the run-in period were randomly assigned on a 1:1 ratio in a double-blind fashion to receive a 10 milligram of dapagliflozin daily or matching placebo. The use of other glucose-lowering agents, some SGL2s inhibitors like pioglitazone or rosiglitazone, was at discretion for the treatment physician. Patients were to return for an in-one follow-up every 6 months until trial completion for laboratory testing and assessment of clinical and safety events and adherence of the trial regimen. patients were contacted by telephone every 3 months between in-person visits. Last video.
But other than that, uh, all of these trials, what we are learning from SGLT2 inhibitors is that the primary endpoint of MACE, which was primarily defined on the basis of the FDA guidance, uh, the benefit is restricted to those with atherosclerotic cardiovascular disease at baseline, and there's a modest benefit. But there's a bigger benefit for heart failure hospitalization and renal benefit that we are seeing in these trials that goes across both the primary prevention and the secondary prevention cohort, which really makes you think whether the definition for primary prevention and secondary prevention, the way we define it for atherosclerotic disease, is really applicable for heart failure or chronic kidney disease. I mean, the biggest take home message for the clinician is sort of stay tuned. We have now 3 drugs that is showing significant impact of this therapy in reduction in heart failure risk, which is one of the commonest complications of patients with diabetes. So as things work through the regulatory agencies and the guidelines, I would not be surprised that in the future, irrespective of the benefit on MACE, just for heart failure prevention, we probably will be using a lot more of these agents in patients with diabetes at higher risk.
Okay, now the conclusion. In patients with type 2 diabetes who had or were at risk of atherosclerotic cardiovascular disease, treatment with the dapagliflozin did not result in a higher or low rate of MACE than placebo, but it did result in a low rate for cardiovascular death, hospitalization, and for heart failure, a finding that reflects a low rate of hospitalization for heart failure. Thank you for your attention. Goodbye.